Good afternoon, everyone, and welcome to this sponsored session by Concept Medical, where we'll be talking about PCI in patients with diabetes, some of the most complex patients we treat with intervention. And really, today we're going to be talking about a next-generation DES and DCB stent platform. We're going to be telling you how this technology works, what's unique about it in comparison to other technologies that you may have not seen. We want you really to understand sort of the performance of it, show you how some of our colleagues are treating it in complex cases. And then with all technologies, we need to iterate. We need to continuously get better, make technologies better. So we're going to unveil also what the next generation of this platform is going to look like. So I think it's going to be very exciting. Please ask questions. I'm here with an amazing panel. My two co-spokespersons are Alex Abizaid and Marie-Claude Maurice, who will help me run the session, and also will get all your questions. So you can either walk up to the microphones, use your app, and put your questions in. We really want this to be interactive. We want your questions answered. And then I also have an amazing panel and speakers, and I'll introduce them quickly. Dr. Fazila Malik, next to me, Dr. Luca Testa, Dr. Juan Iglesias, and Rajneesh Kapoor. Thank you all for being here. So let's get straight into it. Dr. Malik, do you want to start?
So friends and colleagues, it's indeed a great honor and privilege for me to be here today. And you all will agree with me that diabetes is one of the most common comorbidities that we find in our patients who are undergoing PCI. In fact, in a single center registry, they found that around 47% of all the cases they did had diabetes. And when a patient has diabetes, it obviously increases their risk of cardiovascular events and death. And diabetic patients, as we all know, have long diffuse disease, huge atherosclerotic burden. Often the vessels are narrow caliber, calcified, and the corneal lesions tend to be more complex with increased necrotic core volume, increased inflammatory infiltrate, and increased calcification. And so when a patient who has diabetes and this huge atherosclerotic burden gets a PCI done with a drug-eluting stent, obviously there's delayed healing due to slow endothelization and increased inflammatory response. And what does this translate to? It translates to an increased risk of stent thrombosis, which can be acute, subacute, or late, or it can also lead to restenosis, which can be focal, edge, or diffuse. And regardless of what kind of stent a diabetic patient is implanted with, they will have more poor outcome compared to a non-diabetic patient. So in this scenario, the Ebluminous DES stent has come up with certain very interesting innovations which will prove beneficial for our diabetic patients. One is the fusion coating. And what this means is that the stent, as well as the exposed part of the balloon, is coated with the drug. And this facilitates homogeneous drug delivery, and this is obviously good for the patients. But one thing you need to remember is that when you're using this stent, you need to keep your balloon inflated up till 45 seconds so that the drug can be eluted from the balloon. The other thing is that the exposed part of the balloon is coated with the drug, and this addresses the issue of edge restenosis. There is only abluminal coating, and this facilitates monodirectional drug release and less systemic exposure of the drug, leading to faster re-endothelization. And this is a true thin strut stent, so obviously this helps in healing. The drug release is 50% is released within the first 7 days, 70% is released within the 48 days, and this facilitates quicker endothelization. The stent is pre-kimped on the balloon, and then it is coated with the drug. This ensures uniform drug delivery both from the stent as well as from the balloon. So this unique combination of a drug-eluting stent with a DCB will, I hope, answer questions and will be of great value to diabetic patients. And indeed, the abluminous DES has already received CE mark for patients with diabetes. So let me go through a case where this patient we felt was ideally suited to receive this stent. Now, this is the story of a 60-year-old male patient. He was working in the Middle East. He had very severe angina, and he had to come back to Bangladesh for a quick treatment. Now, having surgery was not an option for him because he needed to go back to his job as quickly as possible. And so we thought for this diabetic patient, this stent would be very well suited. So if you look at his coronary arteries, you will agree that it's highly calcified LAD, long diffuse lesion, and there's a large size diagonal which is also severely diseased, typical diabetic coronary artery, right? And the RC was a dominant vessel. This was thankfully free of any significant disease, and it was giving some collaterals to the left system. So wiring the LAD was a bit of a challenge because of the heavy calcium burden, and initially we failed to wire with a run-through floppy wire because of the huge chunk of calcium sitting there on the proximal part. We were then successful with a pilot 50 wire and a microcatheter. However, our pilot was repeatedly going into a septal. Then, with very gentle negotiation, we were able to take our wire down. We pushed our microcatheter down and exchanged that for a rota wire because we knew that we needed to prepare this lesion well to get the best possible results. And obviously, we would need to use some form of ablation to do that. So we did rotablation with a 1.5 burr. After rotablation, we could take our IVUS catheter down at this point, and you can see that we've done some amount of job, but still a lot of work needs to be done. So what we did is, at this point, obviously the diagonal was also important to us, so we wired the diagonal with the help of a microcatheter. We then proceeded to do pre-dilatation with 2.5 20 millimeter NC balloons, and just to keep the diagonal open, we did a very gentle pre-dilatation with a 1.5 by 15 millimeter NC balloon. Once we were happy with our lesion preparation, we took the abluminous drug-eluting stent, and for the mid-segment, we took a 2.5 by 32 abluminous DES. And as I have said, you have to keep the stent deployed up to 45 seconds to ensure proper elution of the drug from the drug-coated balloon. We did that. And we took another abluminous DES and we covered it from the proximal part of the LAD, and we overlapped it with a previously deployed stent, and this also we kept inflated for 45 seconds. We then went on to do post-dilatation, proximal optimization. We rewired the diagonal with another floppy wire with the support of a microcatheter. We removed our jailed wire. We prepared the lesion with the NC scoring balloon. Now, we wanted our diagonal to be safe and free-flowing, so how do we do that? We didn't want too much metal mass for our diabetic patients, so for this vessel, we chose a drug-coated balloon, which we kept inflated for 60 seconds. We did final case, we did report, and at this point, we again took our IVUS. We saw that our stent was properly apposed. There were no expanded struts or malapposition. It was properly sized. There was no edge dissection. We were happy with the results. And this was the final result. And I'm happy to say that this patient has now kept his diabetes under control. He's doing well. He's in regular follow-up whenever he comes to Bangladesh, and it's been almost like 2.5 years that we did this procedure. So in conclusion, we can say that this unique combination of DCB with drug-eluting stent could be an answer for our diabetic patients. Thank you.
Alex?
Yeah, no, great job. Nice presentation, Fazila. My question to you, that I think it was a great indication with DCB for the side branch. How comfortable and share with us your experience with DCB alone for diabetic patient, diffuse disease. If there was more disease in this distal LAD, would you go with DCB alone? I would like to hear from you, not only the DES indication, but also DCB.
Right. So, I mean, often in diabetic patients, we see very long diffuse disease. And maybe the distal runoff is so poor that they're not even candidates for bypass surgery. So for those patients, we regularly use a DCB. So the key to a successful DCB is preparing the lesion well. You need to be gentle. You need to be take your time, do a very good job of the POBA so that the dissection is not severe, it's good flow. And once you've prepared your lesion well, maybe you can use a NC scoring balloon as well. So once it's well prepared and it's not like type C dissection, it can we allow up to type B dissection. So once the lesion is well prepared, go ahead with the DCB.
And my last question, Aizin, is regarding the technique for deployment of abeluminous. Remember, this is not a typical DES. There is some recommendation on how to use. There is a little bit of a learning curve. The IFU, I mean, the company's recommendation is 45 seconds, but some people will feel a little bit more prolonged inflation. How obsessive you have to be with this recommendation?
I mean, you have to be pretty serious about the recommendation. You go up slowly and you stay there for at least minimum of 45 seconds, and then you come down slowly as well. You don't want to come down rapidly because you might end up with edge dissections. Another thing, like if you're dealing with a left main and you're concerned about 45 seconds, your patient might not tolerate, then break up your inflation times. As long as your patient can say maybe tolerate 25 seconds, come down again, then do it again. But make sure that at least you've covered 60 seconds. That's very important.
Thank you.
Dr. Malik, can I ask one more? Yes, we have time for a few more questions. So in a patient like this, diabetic, you did 2 long stents and you treated a bifurcation. In your center, what do you do about DAPT? What do you recommend to the patient afterwards?
Well, actually, for these patients, we would recommend if this patient is not he was not a very high bleeding risk patient, we recommend prolonged DAPT actually.
Longer than a year?
Yeah, longer than a year.
Great. Any other questions from the panel? Okay.
Thank you.
Good. Thank you so much. So we'll move on to the next talk. Luca Testa will be trying to answer the question, is the stent ready for prime time?
Yeah, well, I'm not sure I'll be able to answer, but at least I'll try. And I'll try by showing a couple of situations where the possibility of using this new technology is really a good one. Let me start saying that Fazila is always fantastic in setting up the stage and discussing the technology. And then we need to understand what is the real opportunity of using this technology. Let's start from some, let's say, normal case, 84 years old male with some comorbidities, risk factors. It has been referred to our center for worsening dyspnea and angina in a known severe aortic stenosis, so a mixed situation. So the echo showed and confirmed a severe aortic stenosis with a normal, let's say, sinus rhythm, but left anterior fascicular block. So we do the CT scan, as we always do for this kind of patients, and then we had a surprise, because associated with the aortic stenosis, we found a critical LAD stenosis. The TAVR has been done nicely, no problem at all, I mean, with this good alignment. So we decided to do the coronary angio afterwards, and then we found that this very old gentleman, we found there's tight calcific lesions of the mid-proximal LAD involving a big diagonal over there. So wiring that vessel was not that easy, but finally we made it. And after exchanging the wire, we did this calcium debulking as well. And definitely we upsized the burr from 125 to 1.5 in order to achieve a good result. And we made it. But as you can see, there was a lot of friction, a lot of calcium here and there. So according to the need to speed up the process, because the patient was on the table for a long time already, we had to use a cataract extension. We had to increase the support. So that situations were getting more complicated. However, we managed to deploy for 45 minutes a 3 by 32 millimeter abluminous, and I have to say that the fact that we relieved the aortic stenosis before was actually a great advantage, especially because the patient was able to tolerate. We are discussing about the opportunity of keeping this balloon inflated for a long time, and I have to say, we must follow the instruction, otherwise we do not get the best from this technology. Meaning that if we do an inflation, it is just 10 seconds, maybe 12 seconds, all the drug that can be delivered smoothly on the arterial wall will not be delivered smoothly. So it's absolutely important. And in this specific case, the aortic stenosis relief was absolutely crucial. Otherwise, it would have been impossible to treat this patient with this technology. I post-dilated. It was a very good result, I have to say. But, of course, I wanted to have a closer look. Sorry, it's just a picture. Otherwise, the presentation would be too strong, too long. And there is this dissection, as you can see on the right side of this IVUS, but was not flow limiting. This is a thing that you can easily see every time you do imaging post-stenting. And, of course, as Fazila pointed out, if it's not flow limiting, you should leave this kind of dissections alone. But this dissection gave us the opportunity to evaluate the biological interaction of the stent because it was really at the edge. At 9 months, we called these patients back. And as you can see, there was a complete healing of the dissection, and there was only a minimal hyperplasia. We all know that the process of neointimal hyperplasia and strat coverage goes on from the 6th month to the 12th month. In a year, we see most of the cases of in-stent restenosis. But in this case, we observed fantastic strat coverage and a healing of the dissection. So we were absolutely happy about this type of interaction. So what I can say to answer the question? Well, the acute performance of the abluminus was definitely reassuring. Even a complex lesion with high calcific burden provided, of course, necessary lesion preparation. So in other words, we don't have to rely on the stent itself. We need to do our job, meaning that we need to prepare the calcium, we need to prepare the lesion, we need to prepare the vessel in order to be able to welcome this technology. At a follow-up, the biological interaction of the abluminus and the coronary wall in a diabetic patient was absolutely encouraging, as we observed full strat coverage, which is absolutely important in terms of safety, minimal hyperplasia, which is something that you need to expect, and a smooth healing process of the observed edge dissection. So the question, ready for prime time? It seems ready, but of course we need to, let's say, build up our experience, because now we got a lot of experience, but then before advocating that is absolutely ready, we need to keep learning. Thank you very much.
Very good job.
Thank you. Very interesting and very nice case. I have a question for you because you have a large experience with this device. Does the fact when you treat a complex lesion like that, the calcify, is there a risk of damaging the layer before deployment because you struggle to deliver your device?
Well, theoretically, every time you cross with a device into a highly calcified lesion, there is, let's say, a theoretical risk of damaging of, let's say, scratching the surface of this device. Yeah. However, I was pointed out the fact that we need to do our job, meaning that we need to prepare the lesion in order to place the stent once the stenosis is almost relieved. So in other words, this device, to be perfectly functioning, needs to be treated carefully. So I would say that likewise, DCB, you need to relieve the stenosis before delivering the DCB. In this case, before delivering the abluminus, you need to prepare the lesion. And if it's needed, using debulking devices like I showed in this case. So again, theoretically, yes, I think there is a risk. However, it's up to us to minimize this risk.
Meaning that if you think you pre-dilated well, but you have still friction when you, or it's problematic to deliver the device, you take it off and re-prepare
I have to say that I've never seen one single case of stent dislodgement. Never seen it. Okay. So even when you got some friction, you can really cross the lesion. Okay. In that case, honestly, I say, just deploy the stent, and if you need, you post-dilate. Well, assumed that you are keeping your stent inflated for 40-45 seconds. If you can do that, that'll be fine. And then you post-dilate if it's needed.
So, Luca, let me ask you a question
Please.
to follow on to Marie-Claude. I mean, we have so many stents out there, right?
Yeah.
So for the colleagues who choose a stent from the shelf, Of course, clinical data is important, and we're going to talk about that. But it's also the acute performance, the acute deliverability.
Sure.
That's what the colleagues care about. They want to get their stent to the lesion and not have difficulties. So you've done a lot. I mean, how deliverable is the
Well,
stent
I have to
compared
say
to other stents?
that the procedural and device success with this technology is in the range of 99% of the cases, meaning that is at least comparable with the best in class that we are using since 10, 12 years. In other words, I would say the technicalities of this device are up to date. In other words, I have no concern about using this device in complex lesions.
Okay.
at
So
all.
One thing I'd like to add, the strut thickness is also smaller than the conventional stents like Abbott or Medtronic. It's 73 microns, and the polymer thickness is also less. So that also is an asset for this stent in making it more maneuverable.
Yeah.
And the radial strength is very good.
This is absolutely true, I have to say, and the pushability is always a combination of the stent, the polymer, but also the shaft. And I have to say they found a way to overcome the limitations of the previous generation DES. So nowadays, using these devices is definitely as good as using anyone else. Obviously, the data are the final word because we need to look at the data. But in terms of, let's say, technicalities, it's definitely up to date.
I think that's important since diabetics are some of the most complex patients
Yeah.
we treat, right?
Yeah.
Juan,
Yeah,
you
look,
comment?
well, thank you actually for sharing the case. You are just showing how we can push the boundaries of the device. And I'm coming back to the strut thickness because one concern would have been in these very complex and calcified lesions, the radial strength of the stent. And you nicely show as I mean, what we should do is achieving an accurate lesion preparation using plaque modification devices. I mean, the stent behaves really nicely even in these very complex scenarios. And one good learning point from your presentation is with regards to dissections that you may find after this extensive lesion preparation, and you nicely demonstrated that actually you can leave them behind. Always remember there's some elution of sirolimus outside of the stent markers.
Yep.
It's about 0.5 millimeters beyond each marker. And again, you have this technology also available in the Magic Touch DCB. So in case you need, to cover the full length of the lesion or even the vessel, you can use the same technology, getting from both the drug-eluting stent and the DCB.
Yeah. This is a really good point because differently from other technologies that we have available, the balloon itself is coated with a drug, so you are delivering some drug outside the stent. That's a real good point.
So, Alex, we have some questions from the audience.
The first question is exactly what you asked about deliverability.
Deliverability.
Which I trust is no different from
Not
the
at all.
other best
Not at
in
all.
class DS.
Not
I
at
think
all.
that the issue, Azin, is more towards drug loss. So I think that it's never enough to emphasize the technique of deployment, Mahi. I think that it's important to highlight that because there is lesion preparation, there is some edge dissections. For instance, I tend to, and the recommendation is 45 seconds. Sometimes I like to go to 2 minutes, Azin. And sometimes I see more slow flow, sometimes I see some side branch occlusions. So to stick within the recommendation, it's advisable. 45 to 60 seconds, I think it's important.
Yeah.
Not perhaps too prolonged and not too short, because short, perhaps you're not going to have the biological effect to the vessel wall. So I think that the learning curve is not trivial. It's easy, very deliverable, but you have to pay attention. The stent is not going to be 100%, do the 100% of the job. You have to do a good job as well.
Not at all. I mean, as a matter of fact, if you prolong the inflation, you are basically, having higher rates of debris, higher rate of slow flow, all the possible complications related to stopping the flow for a long time. So 45, I think, is, let's say, a good balance in terms of delivering the drug what is needed, but also, or let's say, having the maximum radial force and, as I say, long-term outcomes.
Beautiful.
Thank you very much.
Great. Thank you, Luca. So we'll go on to our next speaker, Dr. Kapoor. You're going to show us some complex cases.
Thanks, Azim, and literally an honor to be here. So I think the way we look at the disease in India, we have many more diabetics, many more diffuse disease, and I think you all would agree here that diffuse distal disease in diabetics also makes the surgical revasc unfavorable. So we see lots of graft closures because of the distal disease. And that's where we actually require, if we start treating these diffuse distal disease and smaller vessels in diabetics, we require a stent which can do more than the conventional stents. So I think this stent provides that extra punch to give that more beneficial, successful outcomes to all diabetic subsets. So diabetic and cardiovascular disease go hand in hand. We all know the complexity of the procedure, and the results also are affected in diabetic patients. I'm not going in that detail, but India is a diabetic capital of world, almost amounting to all 20% of world diabetic population. So this is where this stent works better, the Envisolution technology, the abluminal coating and fusion coating. Now fusion coating, the coating is done actually once the stent is crimped already. So it is on the abluminal surface of the stent as well as on the parts of the balloon which are there between the stent struts. So that also makes it more favorable for more homogeneous release of the drug and more homogeneous distribution into the endothelium. And this, the biodegradable polymer and edge coating is also an asset. So I'll come to the cases straight away. This is the flavor again in our subcontinent is more diffuse disease, more calcified disease, more distal disease. So these two cases are examples of that. 76-year-old male patient, diabetic, hypertensive, and look at the disease. This is the kind of stuff we get. The calcified LAD, very diffuse in the middle segment, and then there is a lesion in the distal part also. And so obviously these type of disease, we have to decalcify the vessel before really getting a stent in. So rota with 1.25 bar, it was not giving away easily. We have to go up on revolutions per minute, the speed, and then only we can pass this mid-segment deep calcification. So once we have done that, we again pre-dilated aggressively with all balloons up till 2.75 because this part was not giving away. So this is a OPN balloon, 3 millimeter almost, and gave way only at 32 atmospheres. So if we do not take this into consideration and get the stent down, we'll be in trouble. So we have to open it up nicely and have the prepare the bed very well. So then there are two overlapping abluminous stents. After that, it was better. Post-dilated aggressively again with 3.8 at 24 atmospheres. And I'll show you the final result. And this is a circumflex, not great difficulty here in putting or deploying the abluminous. This was relatively a better vessel. And this is how it looked, the LAD after the rotablation and aggressive pre-dilatations and post-dilatations. So if we prepare the bed nicely, I think we can get away with a very good result. And this is what we require in diabetics. So this is another case, 76-year-old patient, diabetic, hypertensive, and again, look at the disease. So this is what I was actually mentioning prior. Now, if we look at the surgical revasc also, there is a distal disease which makes the grafts more unfavorable until the surgeon is doing endarterectomies there and making it more, the results are very good, then only we can actually anticipate very good results, but otherwise there are chances of more graft failures. So this is a typical case where rotatripsy was done because I was not getting a bed prepared nicely. So this is a pre-OCT run, and then I had to do the rota ablation again. This was very heavy calcification. Alongside there is a OCT run here going on. Look at the calcification. Almost more than 180 degrees calcification, deep-seated, superficial, all. And after rota, it still was not an easy run for any device. So did the IVL, lithotripsy with 312 balloon, all through the length of LAD. And this is the post OCT after lithotripsy. I think for the sake of time, I'll skip that, but it showed lots of calcium fractures. And then two long abluminous stents, and look at the OCT now post stenting. We got very good areas throughout the vessel, well expanded. We have done a lot of decalcified maneuvers, both aggressive rota and lithotripsy, and then a stent almost near the apical turn of the LAD. So it took 3 stents. There was 2.5, 12 at almost the distal part of LAD, and then 2 long overlapping stents. And this is OCT, which looks great. So idea is, to conclude, I would say, in these kind of subsets where we find a lot of diffuse and extensive disease and calcified disease, no doubt that we need to prepare the bed very aggressively before getting the stents, but we also require a stent which has that extra punch to deal with these diabetic subsets. And this is one stent. With our vast experience on it, I think we are fairly comfortable with medium to long-term results in diabetic subset with this stent. Thank you.
So, Dr. Kapoor, so maybe since it's very about complex cases, maybe I'll ask some questions about the cases. So maybe the second case, there was a temporary pacing lead. Why was there a pacing lead, just out of interest?
Yeah, so normally we do, whenever we do rota, mostly to the right coronary artery, we do the pacing, temporary pacing lead. It was LAD, usually we haven't found any issues with that, without pacing also, but just for sake of it, patient was having some pauses on the ECG prior. I mean, it was...
some pre-existing conduction disturbances.
Yes. So we thought better to be on the safer side.
And then when you're dealing with such a long LAD, did you give any thought to maybe a hybrid approach, combining maybe some drug-coated balloons with the stents to decrease stent length?
Yeah, so we use a lot of drug-coated balloons also. The Magic Touch from this same company is a very good balloon. But mostly we restrict ourselves to smaller vessels and the side branch. So in this case, the caliber of the vessel was very good, almost 3 to 3.5. The whole length of overlapping stents was 3.5. Down just near the apex, it was 2.75. So in smaller vessels, yes, our inclination is more towards drug-coated balloons rather than stents. So in this specific case, the reason for using stents was the caliber.
Well, receive any questions from the audience?
There are questions from the audience. Thank you for a nice demonstration. Regarding radial stents, would you use abluminous stents in left main?
Yeah, we have used abluminous in left mains in quite a number of cases, and as I mentioned, as for the radial strength is also concerned, we haven't found any issues with that. We are pretty comfortable with this. Only thing is the expansile limits we need to work on. So expansile limits of this stent are still 0.5 to 0.75. Now we have more stents available where the expansile limits are 1.5 to 1.75 more than the natural size of the stent, like Megatrons or this thing. So if that works out, if we have a 4 millimeter vessel and we go with the 3.5 abluminous, we are pretty comfortable.
Okay. Yeah, that's a good question, because strut thickness always compromise a little bit radial strength. But cobalt chromium and having a good lesion preparation, I don't think this is going to be a concern. Yeah. The other question was regarding imaging. So if you recommend, I think that in one of the cases you use OCT, right?
Yes, so we use OCT and IVUS almost 50-50 in our cases. 50% consumption is OCT and 50% IVUS. I think a resolution of OCT makes us believe that probably this is a better imaging, but then we have to keep in mind the contrast load, we have to keep in mind the kidney functions and all those things. So IVUS is also very good, but the distal edge dissections or the appositions, we find more comfortable with OCT.
Yeah. I have a question actually related to the management of the patient during this kind of very complex procedure. So considering how much you have to debulk the lesion, multiple rotablation, multiple inflations of balloons, and then also you need to keep inflated this abluminous for a few seconds. Would you recommend a specific, more aggressive antiplatelet, anticoagulant regimen during the procedure, or is it not really needed?
I think during the procedure or pre-procedure, we usually use ecosprin and ticagrelor as the best combination in almost all our cases. And the long-term usage of DAPT, I concur with Dr. Fazila, which that we want to use more longer duration of DAPT in such cases, more than a year. And specifically, if these are LADs and overlapping stents and calcified vessels, and there are no bleeding issues, then I think better we try to use it for 2 years and then cut down with one antiplatelet.
All right, thank you.
Another interesting question, Marie-Claude, there is no data, Somebody from the audience is asking if there is any data comparing abeluminous with Lima at long-term follow-up. I wish we had that data, right?
Yeah.
That's a great randomized trial to be performed in the future.
It's worthwhile.
But I think that with the two-year follow-up with ability, we might have more data at longer term with abeluminous. But right now, there's no such data. And Fazila, let me ask you a question. In your practice, you have a high-volume practice. In terms of diabetes and revascularization, what is the percentage of patients that you end up sending to surgery? You had a surgical case that, for, of course, practical reasons, he went to PCI. But in your practice, I would like to hear all of you, Azin, if we have time, the percentage of patients diabetic patients that you send to surgery in your practice.
Well, actually, it's more like a heart team approach, and ideally, all diabetic patients we do consult, but there are exceptions. Like this patient was an exception. He needed to avoid surgery at all costs because he would lose his job. So for exceptions, yes, but otherwise, they always get referred for.
That's a good answer. Heart team for the decision making. What about you, Juan?
Well, the same. All these cases are discussed in a multidisciplinary team with surgeons. We restrict the indications for PCI in patients who are turned down by surgeon, or in all patients with diffuse distal disease, which are not targets for a graft, actually. And the combination of a stent proximally and a DCB distally makes the job very easily. But I think it's a case-by-case discussion. Most of our patients are still operating.
Luca, any algorithm that you recommend? Single vessel?
Oh, I have to say that. Honestly, my situation is more or less the same as one, because I honestly believe in the guidelines, especially for diabetic patients. And every time I see diabetic patient with tricuspid disease or left main, I just call the surgeon. And unless this patient, definitely strongly refuse cabbage, just for cabbage. Just go for it. There's no discussion, I have to say. No, our team, it's me saying to the patient, look, you are a good candidate for surgery unless you refuse. But honestly, if you consent the patient in the right way, you'll understand.
You will understand. Azim, not all diabetic patients were born the same.
Yeah, exactly. Not all diabetic patients are born equally. I have, if a patient comes to me and they have a few focal lesions with a lowish syntax score, and I'm not compromising their distal graft area where they could get grafts in the future, I'm happy to offer them stents because I'm going to maybe do shorter proximal stents. I think, I'm more and more reluctant to do long overlapping stents in diabetics. But when you look at them, also, you need to be sure that there's distal targets, right? Some of the cases we saw today, they were not great distal targets where you're going to attach a lemur. And I think the last thing I also do when I do send patients is I choose my surgeon. So I don't know what it's like in your hospital, but in every hospital, there are multiple surgeons, and some of them are better than others. And so when I have a diabetic, I always choose the surgeon who is most likely to give me arterial grafts, more than one.
Yeah.
At least a lemur, but I want another arterial graft, whether that's the other mammary or a radial. So I think you also, if we're going to give these patients the best revasc surgically, that means arterial grafts, if possible. If they're not too old, one of the concerns is always if you take a diabetic and you take both of their lima and rima, that the sternal closure may be more difficult compared to a non-diabetic. But there are also ways now the surgeons things they can do to stabilize the sternum and make sure it heals.
Yeah, that's a great point. I think that stent overall equalized a little bit the results for multiple operators, but they still, a good surgeon for arterial graft in a diabetic diffuse disease made all the difference in mortality, including mortality. Right?
Absolutely.
Yeah. Hanesh, you had a comment? I thought you want to make a comment.
I think one thing which I like to add, many of the trials which are there with surgery versus multiple stents in diabetics, I think they are with generation 1 stents. I think with the kind of more advancements in the stent technology like this, we should have a recent data to actually see that how these two subgroups are faring. So we are also a part of one big trial going on, but that's not a randomized comparison. But I got a call from Park Group from Korea. They are planning this trial with a recent generation of stents with diabetics in triple vessel disease. So recent data will give us more light on this subject.
And the last point, Zine, if you allow me, is how tough we should be controlling glycemic control. Because remember, from the Freedom trial, the adherence, and this is a randomized control trial that we keep calling these patients every other month, right? So it's very low. So the other thing is the combination of the job that we do mechanically and pharmacotherapy.
So I think we mustn't forget that. I think also lipids. That, I always try and teach my fellows that we always have to be cardiologists first,
Exactly.
and then, technicians or put stents in second. And so I think whether my patient goes for surgery or PCI, looking at their lipids, looking at the sugars and getting the HbA1cs are very important. But we have one great talk to really bring it together and talk about what's coming in the future. So Juan, what's next?
Thank you, Azim. It's my great pleasure here to discuss with you a quite different concept from the one we've been discussing today, which is a newer generation drug-eluting stent technology, and I will share with you some insights. These are my potential conflicts of interest. So why do we still need innovative drug-eluting stent designs in 2024? So when we look at these data, based on the fact that actually newer generation drug-eluting stents are the gold standard for PCI in all patient and lesion subset, we'll realize that actually these newer generation drug-eluting stents are still associated with a persistent very late stent-related outcomes after DES implantation, and this occurs at a rate of approximately 2% a year. It accrues over time without any evident plateau. So this discloses a need for newer generation drug-eluting stents to be designed to overcome these limitations. We'll discuss here about a newer device, which is the Abluminous NP, which is different from the one we just discussed a few minutes ago. And this device has unique properties that make this stent different from those currently available commercially. First, it has a polymer-free coatings to reduce the polymer-induced chronic inflammation, to avoid persistent fibrin deposition, and this is aimed at enhancing vascular healing and promoting complete and faster reendothelialization. And this may allow, as we discuss later, shorter DAPT durations in high and non-high bleeding risk patients. It has an abluminal coating that facilitates the monodirectional drug release and reduces systemic drug exposure, and this targets the drug into the vessel wall to enhance reendothelialization. As mentioned with the Abluminous DES Plus, it has a fusion coating so that the stent and as well the exposed part of the balloon, proximally and distal ends of the balloon, are also covered by the coating to facilitate homogeneous drug delivery. So it's a hybrid drug-eluting stent and DCB concept to address the entire area of disease and focal and edge restenosis. And once again, mentioned here with this device as well as for the Abluminous DES Plus, the recommendation of 45 seconds inflation time. And it has a unique nanoactive technology to facilitate the acute and sustained drug release into the vessel wall. So this slide summarizes the nanoactive technology where sirolimus submicron particles are encapsulated into a phospholipid drug carrier and are exposed to both the stent of the balloon, and as you can see here in electronic microscopic images, both the stent and the exposed parts of the balloon are coated with sirolimus, and this ensures 100% coating and uniform distribution of the drug into the vessel wall. So what is the mechanism of action? First, we have a burst drug release from the stent and parts of the balloon covered by sirolimus at the time of stent deployment. Then the drug is released from both the stent and parts of the balloon at the time of expansion. And when the balloon is deflated, there's a longer duration drug release from the stent, which converts this device into a BMS at 14 days. So this slide shows the coating distribution. As mentioned previously, you can see here the stent platform and the coating distribution, which extends 0.5 millimeters beyond the stent distal and proximal marker, so that the coating is extending from proximal marker to distal marker outside of the stent boundaries. Looking at the stent platform, it's similar to the Abluminous DES, a cobalt chromium 73 micron strut thickness with a peak-to-peak alignment, and a hybrid cell designed with open cells in the mid-segment and closed cells in both proximal and distal ends. And this is important for side branch access when treating bifurcation lesions, as I will show you later. And the overall stent is designed with a zero foreshortening concept. Here you can see the in vitro sirolimus release, which has an initial burst phase where 50% of the drug is released within the first 7 days, and then the total drug release within 38 days to ensure the arterial healing and facilitate endothelization. So what could be the potential advantages of this stent when compared to previous generations? So there's no polymer, and this reduces and may reduce inflammation and facilitate vessel healing. It reduces the end transit drug loss due to the encapsulation of sirolimus with phospholipids. The homogeneous expansion and drug distribution ensures a uniform deposition of the drug on the vessel wall, which may improve the in-tissue drug bioavailability and the effective drug transfer to the deepest layer of the vessel wall. So we have to recognize that current evidence is limited to small non-randomized study currently. So here we have the NanoActive first-in-man study, which was a prospective non-randomized multi-center clinical study performed in India with 2 cohorts of patients. First cohort with de novo corneal lesion, cohort B, which was an all-comers patient population with coronary artery disease. And as we can see here, very high procedure device and lesion success rates with appreciable outcomes at 6-month follow-up. The NanoActive post-marketing study, which was a prospective, non-randomized multi-center registry performed in India to assess the safety and efficacy of this abluminous NP device in patients with coronary artery disease. The primary endpoint was MACE as a composite of cardiac death, target vessel myocardial infarction, and clinically indicated target lesion revascularization within 12 months. And as you can see here, the clinical outcomes of 12 months showed very low event rates, a 2.2% MACE rate, no cases of TLR or TVR, 1.1% target vessel myocardial infarction rate, and cardiac death 1.1%. And importantly, no case of stent thrombosis shown in this study, which included 90 patients. So let me show here maybe 2 subsets of patients where this device could be useful. We are talking a lot here about patients with diabetes. Here is a case that we presented here 2 years ago during a Life in the Box session. It was a 71-year-old male with type 2 diabetes, 3-vessel coronary artery disease with previous stents on the right coronary artery 2021. And he had a previous PCI of LAD CTO with wide drug-eluting stent as well during in 2021. He presented with exertional angina on optimal medical therapy, and the cardiac PET-CT showed anterior wall reversible ischemia and the lateral wall transmural necrosis. This is a baseline coronary angiogram. As you can see, a CTO of the proximal circumflex where no viability was demonstrated with non-invasive imaging. And the patient here showed, as you see, a severe ostial LAD stenosis with severe calcification, a patent stent on the mid LAD, and patent stents on the right coronary artery with epicardial collaterals to the circumflex CTO. We went on preparing the lesion with non-compliant balloons, high pressure, 3.0 and 4.0 by 15 millimeters, as you can see here, to from proximal to ostial left main. And this is the abluminous NP 4.0 by 32 millimeters. As you can see, it's quite remarkable how you can appreciate the visibility of the stent, which allows a very accurate placement at the ostium of the left main. Importantly, the 4.0 platform expands up to 5.5 millimeters, which allows to fit most of the left mains that we are currently treating in clinical practice. The procedure here was guided by OCT pre and post PCI. So the balloon was inflated during 45 seconds, which is also possible in patients with the left main coronary artery disease, assuming that actually the LV function was preserved, which was the case in our patient. The stent was then post-dilated 4.0 by 15 up to 22 atmospheres. Easy recrossing of the side branch into the intermediate artery pot with a 4.5 balloon, and then a kissing balloon with a sirolimus coated balloon in the intermediate branch, and then a final report with a 5.0 non-compliant balloon at 60 atmospheres. And you can see here the final result, which was pretty acceptable at the end of the procedure. And the patient came back earlier this year for the 2-year follow-up, and you can see a quite nice angiographic result at 2 years of follow-up with only minor diffuse hyperplasia in the stent, which was confirmed by OCT. The patient was symptom-free at 2 years of follow-up. One other potential indication for this device is the challenge of treating patients with ST elevation myocardial infarction and the need for prolonged DAPT in some of these patients. This is a case of a 76-year-old female with dyslipidemia and hypertension who presented with a posterior ST elevation myocardial infarction. Here, as you can see here, an occluded proximal circumflex artery. Here you can see on the left-hand side, no disease on the LAD and a quite severe stenosis on the proximal right coronary artery, which was subsequently treated during a staged procedure. So the primary PCI was actually performed according to an hybrid approach. We use sirolimus-coated balloons in both the distal circumflex and the OM branch, 2.5 by 20 balloons here sequentially applied. And then we treated the proximal segment with a 275 by 20 abdominis NP, which was subsequently post-dilated with a 3012 balloon. And as you can see here, the final angiographic result with patent vessels distally, some dissection at the ostium of the distal circumflex. And here you can see the angiographic follow-up at 6 months, showing a quite complete regression of the dissection and a very nice angiographic result with a simple patient which remains symptom-free after treating as well the right coronary artery. So this device may have some advantages in treating patients with ST elevation myocardial infarction in whom shorter duration of the APT may be considered. And that's the reason why we designed the STARS-DAPT randomized clinical trial, which is the first randomized clinical trial investigating the abdominis NP in clinical practice in this case among patients with ST elevation myocardial infarction. This is an ongoing study which will include 350 all-comers patients with STEMI who will undergo primary PCI with the abdominis NP drug-eluting stent, and these patients will be randomized in a one-to-one fashion to receive either P2Y12 receptor inhibitor single antiplatelet therapy after a short course of aspirin, which will be discontinued at hospital discharge, and these patients will be compared to a conventional DAP arm where the APT will be maintained according to guidelines between 6 and 12 months. The primary endpoint, which will be analyzed according to a non-inferiority hypothesis, would be a combined endpoint of efficacy and safety. The primary efficacy endpoint would be major adverse cardiac events, defined as a composite of death, MI, stroke, and urgent target vessel revascularization, and defined definite and probable stent thrombosis at 12 months. And the primary safety endpoint would be with bar class 3 or 5 bleeding events at 12 months. So we look forward to share these results within the next year. So, ladies and gentlemen, my conclusions: abdominis NP sirolimus eluting coronary stent is a novel drug-eluting stent with a unique hybrid design that combines both a polymer-free sirolimus eluting stent platform and a sirolimus coating balloon. So this is a true hybrid polymer-free drug-eluting stent and DCB technology, which is unique currently. No other technology available on the market has the same concept. Abdominis NP sirolimus eluting stent is designed to reduce polymer-induced chronic inflammation, enhance vascular healing, and promote complete and faster re-endothelialization with the aim of overcoming current limitations of contemporary DES technology and facilitate shorter DAP duration. And the safety and efficacy of a P2Y12 inhibitor single antiplatelet therapy compared to conventional dual antiplatelet therapy after PCI with the abdominis NP drug-eluting system in patients with ST elevation myocardial infarction is currently investigated in the STARS-DAPT randomized controlled pilot study. And with that, I would like to thank you for your attention.
Alex, anything from the audience?
Yeah, there is one question here, very provocative one, is what do you think about mixing stents and DCBs with different anti-mitotic or anti-proliferative actions in terms of substances for diabetic patients?
Well, I mean, we do not have, as probably the audience know, data to support one or the other of the approaches. We only have extensive experience from years using paclitaxel eluting balloons or coated balloons with sirolimus eluting stents. And actually, to be honest, I will be happy to hear from the panel here. I did not experience any kind of problem by mixing a sirolimus eluting stent and a paclitaxel coated balloon. And I think that currently this problem may be overcome by the emergence of sirolimus coated balloons. And when we discuss about this technology, and which is quite important to know, is that when we use Magic Touch sirolimus coated balloons as well, we are using the same technology with the same drug, with the same nanoactive technology around along the entire vessel, which is something that is even better. But to be honest, we do not have data even in all comers, even less in diabetics. But as Zim mentioned, I think that this is something that we should now target. It's trying to reduce the amount and the length and diameter of stent that we are using in diabetic patients, trying to combine as much as we can with the drug-coated technology, either paclitaxel or sirolimus. I mean, it's only by reducing the amount of metal that we can get the best results in treating this very challenging patient subset.
You know, that reminded me 20 years ago, Azim, when we had Cypher and Taxus.
And Taxus, yeah.
And there was a restenosis of Taxus. For revenge, we used the Cypher and vice versa.
Absolutely.
But right now, everything is Lyman's, right? Except for DCB
drug-coated balloons.
And we might do that if we see continuous ISR with one versus the other, might change
I'm
the
sure
drug.
with 2 balloons available,
We'll
there are
do
people
that.
who are already doing that and swapping. So, Marie-Claude, it came up before, but what data is there for this abluminous DES? Are there any large-scale studies? Maybe not everybody knows about. You mentioned one earlier. Can you maybe briefly tell the audience about it, and when will we have the first data for ability?
Oh, for ability, it's today. Huh?
Yeah.
Today or tomorrow?
Today.
Today?
No, it's
In
today.
this very theater here.
Same place,
Okay.
later on.
After 3:15.
Yeah.
Okay, so if you want to actually see data from a large-scale randomized study, come back to this theater later today after 3, I think. Great.
Yeah.
I see a question from the audience.
Marie-Claude has a
I have
comment.
one also. Yeah.
Yeah, thank you very much for the interesting presentation. My question is the role of drug-coated balloons in the treatment of acute coronary syndrome like STEMI. Is it as effective as using a drug-coated, drug-eluting stent? Thank you.
Well, as you know, there are some concerns about drug transfer into the vessel wall, which can be impeded by the presence of thrombotic material in the vessel wall. We have small data from Finland, a 70-patient trial with DCB in treating STEMI patients, which showed actually have very nice, promising results. I think we still need larger trials to demonstrate its feasibility beyond the fear of not getting the full drug transfer into the vessel wall in this very challenging setting. I have to say that more and more I'm using this technology as far as combining with a short drug-eluting stent in order to treat only the culprit lesion as far as we can with a shorter stent, and then extend the treatment with a DCB distally. But I fully agree with you that maybe we need some more data before embracing the technology in this very acute thrombotic scenario.
Thank you so much. And what about the efficacy of the DCB in terms of different artery diameters, let's say 2.2 and 3.7 or 3.5? Is it equally effective in both or different?
Well, in terms of
So-
I think in terms of biological effect, it shouldn't be different. The only thing is that the larger vessel can accommodate more intimal hyperplasia, and the event rate might be a little bit lower.
Yeah, we've not seen any difference. In general, people have preferred to do smaller vessels because I think that's a great place to learn how to use drug-coated balloons. You feel more comfortable. And just because I think many operators are uncomfortable about leaving a dissection in a 3.0 vessel, which is more proximal. But there are many centers that are doing it with a lot of experience. There's a number of randomized trials being done right now out for de novo disease where there's no exclusion for vessel size. So I think we'll really have the answer to your question probably within the next year or two.
Thank you.
Well, from personal experience, we are treating de novo lesions since now 3 years with up to 4.0 millimeter vessels. I mean, with DCBs, and to be honest, as far as you get a very nice lesion preparation, the outcome results are really good. And as mentioned by Azim, we are waiting for the Transform 2 and the Solution trial de novo, which are 2 large randomized clinical trials which are assessing this kind of de novo coronary artery lesions up to 4.0 millimeters.
Small question. I'm very interested in the new device you presented to us. It's polymer-free, meaning you expect less inflammation. Is the dosage of drug the same? Do we expect more efficacy or the same efficacy?
No, the dosage is the same. The concept behind is trying to avoid having a polymer behind. As you know, Marie-Claude, we have now long-term data of studies that did not show a benefit of polymer-free drug-coated devices over conventional permanent drug-eluting stents. But I mean, it's more of the overall concept. So it's not just looking at the polymer-free platform. It's just having the correct drug at the correct dosage and with a full, a coverage of the elution over the entire device. So beyond just the polymer-free concept, is trying to minimize as far as possible all possible inflammation in the vessel wall by this design.
Thank you.
So I think we've come to the end of a really great session on PCI in diabetic patients with a very novel technology. I think the speakers really highlighted for all of us how important this diabetic subgroup is, how much more complex they are, and why we need such novel technologies such as the Luminous DES and the newer version. There'll be clinical data here today for those who want to see. There was a lot of interest in drug-coated balloons, so a little shout out for Concept Medical. There is another session this afternoon in the TNT session just on drug-coated balloons. So if you want to know more about Magic Touch, come to that. And yeah, thank you very much for all the questions. And to all the speakers.